Good evening, doctors. My name is Rahul Desai, and on behalf of FDC and MedTalks, in our journey of 52 weeks of Diabetes Essentials, I hereby welcome you all to today's live module brought to you by Enazal Zero and in memory of Dr. K.K. Agarwal, sir. Dear viewers, till now we have covered five topics in drug treatment modalities, and those are biguanides, sulfonylureas, meglitinides, thiazolidines, and DPP4 inhibitors. And today, sir, will take us through alpha glucosidase inhibitors. If any of the viewers have missed to attend the previous sessions, they can view the same on the same platform in the archive section. Now, before I hand over the platform to sir to take us through today's milestone in our 52 weeks journey, let me have the opportunity of announcing the quiz winner's name of last episode. And the winners are from West Bengal, Dr. Shantanu Kumar Bhattacharya. From Maharashtra, we have Dr. Bina Gesota, Dr. Seema Shah, Dr. Kulbhushan Tandon, Dr. Dharmika Tandon, and Dr. Sopan Tuse. And from MP, we have Dr. Deepak Paradkar. So, congratulations to all those winners who have attended and won the goodie bag of last episode. With this, I hand over the platform to Dr. Sanjay Kalra sir to take us through today's module.
Thank you, Rahul, and warm greetings to everybody. It's a great Sunday. Our boys and girls are doing very well at the Tokyo Olympics. PV Sindhu won a bronze medal for us, and we hope that our hockey boys are also able to follow suit and gold back to India. Let's talk today about alpha glucosidase inhibitors. So, like Rahul said, for the past 5 weeks or so, we've been talking about different aspects of uh, drug therapy of diabetes. It is difficult. It is not an easy topic to discuss or to handle. But one by one, we've understood the various drugs that we have. We've been able to classify them. And with today's episode, we should be able to have a fair idea finally of when to use which oral drug. We'll keep on talking about insulin, and over the coming weeks, we will revisit this again and again so that we are able to internalize all this information and make it part and parcel of our daily knowledge. So, in memory of Dr. K.K. Agarwal, sir, let's talk today about drug modalities, and today we focus on alpha glucosidase inhibitors. The term itself tells us what these drugs do. There is an enzyme known as alpha glucosidase. This is present in the gut. If it is called glucosidase, it means it is breaking down glucose bonds. What this enzyme does, alpha glucosidase, is it breaks the complex carbohydrates into simple carbohydrates. So it will break starch, for example, into sucrose, and then sucrose is broken down to glucose. When complex carbohydrates are broken down into simple carbohydrates or simple sugars, they get absorbed. If we are able to inhibit this enzyme, we are able to inhibit the breakdown of carbohydrate. We will slow down the absorption of carbohydrate, and therefore these drugs will act like a carbohydrate restriction mimic. They will tell the body that carbohydrate is restricted. Actually, we did not restrict carbohydrate intake. We are eating all the carbohydrates, which is part and parcel again of our Indian diet, but we are inhibiting their absorption and assimilation. So they are calorie restriction and specifically carbohydrate restriction mimics. Why were these drugs developed? Let's look at the definition of diabetes. Diabetes is a state of carbohydrate intolerance. We cannot tolerate carbohydrates. If we take small amounts of carbohydrates in diabetes, we are able to manage them. But the moment we go above a particular level, we cannot handle the carbohydrate load that is put upon us. Because of that, carbohydrate levels or glucose levels rise, and that is the definition of diabetes. If we can inhibit this, and we can do it using two drugs that are available in our market, acarbose and voglibose, perhaps we can prevent hyperglycemia and prevent diabetes itself. So like we've already mentioned, this is how alpha glucosidase inhibitors act. They prevent the breakdown of oligosaccharides to monosaccharides. Because monosaccharides are not formed, they are not absorbed, Because they are not absorbed, they do not reach the circulation. Because they do not reach the circulation, there is no hyperglycemia. So alpha glucosidase inhibitors, when given along with a meal, will prevent postprandial hyperglycemia or postprandial spikes. Because they reduce postprandial glucose levels, they are able to reduce endothelial toxicity. The endothelium is the lining of all the blood vessels in the body, whether in macro or in microvasculature. When you have glycemic variability, sometimes high glucose, at another time low glucose levels going up and down, this variability itself acts like a toxin or like a poison upon the endothelium. The endothelium bathes all the organs of the body, including the macro and microvasculature, like we said. And if you have postprandial hyperglycemia, that is independently associated with complications of diabetes, chronic vascular complications of diabetes. So alpha glucosidase inhibitors are able to reduce these complications. Not only do they control post-load or post-meal glucose, they also reduce fasting glucose by what is known as the domino effect. So glucose levels keep on going throughout the day, and that is why the next day also you'll have low glucose. The beauty is that alpha glucosidase inhibitors are able to circumvent two paradoxes. Now, let us take sulfonylureas just as an example. When you give sulfonylurea, you increase the insulin level and you bring down the glucose level. Bringing down the glucose level is good. But if you increase the insulin level too much, you are actually worsening hyperinsulinemia, which is associated with insulin resistance. And hyperinsulinemia will come with its own bag and baggage of side effects or corollary effects, like weight gain. That is why, if you remember earlier when we spoke about sulfonylureas, we highlighted the fact that glimepiride has less insulinotropic effect. Glimepiride does not increase the level of insulin as much as would be expected from its pharmacokinetics or dynamics. This is because it also has extra pancreatic effects. But still, insulin will go up if you are giving glimepiride. Insulin will go up if you are giving exogenous insulin. If you give an insulin sensitizer, insulin levels come down. This we will see with SGLT2 inhibitors, with GLP-1RA partly, and also with metformin. With alpha glucosidase inhibitors like acarbose and voglibose, glucose levels come down and insulin levels also come down. So this is one good thing. It is able to break the hyperinsulinemic paradox. Another paradox which AGIs are able to break is one that is called the KG-A1C paradox. Now, when we try to bring down the HbA1c, sometimes weight gain occurs and kg or weight goes up. So you are bringing down the HbA1c, reducing complications, but at the same time, as a corollary, you are increasing kg or body weight, and overall, you are increasing complications when weight goes up. So alpha glucosidase inhibitors are able to break the KG-A1c paradox. They bring down both weight or they are weight neutral, and also they bring down glucose levels. Because of their mechanism of action, they have a very sustained effect. Whatever effect there is, it remains sustained because it is not dependent upon the beta cell. It is just dependent upon food, upon the GIT. And that is why in the International Diabetes Federation guidelines, AGIs are recommended as first, second, or third line options. In China, acarbose is first line option. Acarbose and voglibose can be combined with insulin. They can also be combined with all the oral drugs, metformin, SUs, DPP4 inhibitors, glitazones, even SGLT2 inhibitors. And irrespective of where the patient has come to you with, at what level, at what stage the patient has come, we can use these drugs. In India, usually we do not use alpha glucosidase inhibitors as monotherapy, though this is a very common use in China. However, we do use them as second line or third line therapy. One added advantage that AGIs have is their cardiovascular safety, not only in diabetes, but in pre-diabetes as well. The STOP-NIDDM trial, STOP NIDDM trial, was done in persons with pre-diabetes, and what it found out was that when you give acarbose, you can prevent the progression of pre-diabetes to diabetes very safely, and you can also reduce cardiovascular events. So this was a CVO. It was not a CVOT. It was not designed like that, but it actually showed that cardiovascular outcomes can be improved if you act in the pre-diabetes phase. I would like to take this opportunity to remind all of us and to inform all of us that the 14th of August this year is being celebrated by the Endocrine Society of India as World Pre-Diabetes Day. Why have we chosen 14th of August? It goes along with our Independence Day. So independence from slavery, independence from colonialism, and also independence from diabetes. And 14th August is exactly 90 days before 14th of November, which is World Diabetes Day. Alpha glucosidase inhibitors are one of the drugs that are safe for use in all age groups. You can use in pre-diabetes as well as diabetes. In India, actually, acarbose is approved for use in type 1 diabetes as well, along with insulin. For pregnancy, they are category B drugs, but you can use in moderate renal impairment. We spoke of cardiovascular events, and the benefits of AGIs are that the risk of myocardial infarction goes down, the risk of all MACI goes down, 3-point MACI, and also many other biochemical markers or biomarkers like inflammatory cytokines, platelet activator markers, oxidative stress markers, coagulation levels, factors, all these come down with acarbose. We use it orally with meals. So if patient is taking 2 meals a day, 2 doses. If 3 meals a day, 3 doses. There is a wide range of dosage. Acarbose you can give from 25 to 100 milligram 3 times a day. Though I would very strongly suggest against using 100 milligram three times a day. It will cause a lot of flatulence. 25 to 50 milligram 3 times a day is what is used. Voglibose can be used 0.2 to 0.3 milligram with meal twice or thrice a day. It will reduce insulin levels. You can use in moderate renal failure. If you wish to use in pre-diabetes, they are very safe to use, very, very safe to use. You can use in younger and adolescent people as well. And they are weight neutral, CV safe, virtually zero risk of hypoglycemia. But we must be aware of GI intolerance. When you use these drugs, you can counsel your patients that it will not only help us bring down glucose levels, but will also reduce body weight slightly, improve blood pressure control, improve triglyceride levels, and also decrease CV events. The side effects we must be aware of. Because it delays complex carbohydrate digestion, it can cause flatulence or diarrhea, very rarely abdominal pain. But patient may complain of sense of fullness in the abdomen, that is upper abdomen, or flatulence, lower abdomen. Hypoglycemia is very rare. But if at all it occurs, it will occur because of sulfonylurea or insulin use. And if at all it occurs, remember that you cannot give sugar to control hypoglycemia due to acarbose or voglibose, because it is going to prevent the breakdown of disaccharides into monosaccharides. So we will have to give glucose. Either you give glucose orally, or you can give sublingual glucose. The patient can, maybe take honey, just keep it over the tongue, or keep a sugar cube in the mouth. So it will be per oral or sublingual absorption of honey or sugar that is occurring. If you want to give per orally, then it has to be glucose. It cannot be sucrose. How do I use it in my clinic? I use it sometimes as second line or third line drug along with metformin. I start low, maybe a dose like voglibose 0.2 milligram BD along with metformin, and I go slow. I up titrate slowly. Take the tablet with the first bite of the meal. It is safest that way. GI side effects will be minimal. I do monitor GI health. Usually the issue with acarbose and voglibose is GI side effects. But all GI side effects are not because of drugs. The commonest causes in my clinic will be amoebiasis, giardiasis, lactose intolerance. The average milk intake of Haryana is something like 1 liter a day. If so much of milk is being taken and the patient is lactose intolerant, obviously GI side effects will come. You cannot blame the tablets because of that. For that. So amoebiasis, giardiasis, lactose intolerance, these are common conditions. In people with long-standing diabetes, another common cause of GI dysfunction would be diabetic gastroparesis. It can also be metformin intolerance. So how do we have a high clinical suspicion for diabetic gastroparesis? Long history of diabetes, long history of uncontrolled diabetes, history of other autonomic dysfunction, which can be pseudomotor, that is related to sweating, or it can be genitourinary, or it can be cardiac autonomic like postural hypotension. If there is other autonomic dysfunction, the chances of diabetic gastroparesis will be more. Like I said, I use it sometimes as a second line along with metformin. I have very, very rarely used it as first line for pre-diabetes. But now with the growing interest in pre-diabetes management and diabetes prevention, why are we managing pre-diabetes? To prevent diabetes. I think my use of these drugs might increase now in the weeks and months to come. I also use agarbose and voglibose very frequently along with insulin. Supposing I am giving premixed insulin with breakfast and with dinner, but lunch is not covered, I'll request the patient to take a low carbohydrate lunch and also add a tablet of metformin and voglibose or metformin and acarbose at lunchtime. At other times, if we are giving premixed insulin, things are fine, but the postprandial excursion is high. Patient has done whatever he or she can do to change the diet, to change exercise, but still glucose levels are rising very high. Now, ideally, it would be ideal course would be to change to basal bolus insulin, but then that is 4 injections a day. Patient is not willing. So, along with the whatever premixed insulin I'm giving, I can give acarbose or voglibose. That is safe and we can use it. So, these are some clinical tips from my practice. Let's go to our questions for the week. But before that, let's look at the answers of last week's quiz. So, last week the question was, for an obese or overweight type 2 diabetes patient, what is the most appropriate therapy? And you want to achieve weight loss as well. And the answer was liraglutide and dapagliflozin. The other question was, Miss Y is having a low output of urine. What would we want to give? And the answer is you would want to give a hypotonic solution so that there is more water that is infused. And when more water is infused, more water will come out. Our questions for this week: acarbose, alpha glucosidase inhibitor, which we just discussed. It is used to treat hyperglycemia. Which of the following is a correct mechanism? A. Acarbose acts on the adipose tissue. B. It increases insulin sensitivity. C. It delays absorption of starch and sucrose. Or D. All of the above. Let's repeat the question. How does acarbose act? Does it act on the adipose tissue or on insulin sensitivity? Or does it work to delay the absorption of starch and sucrose? Or perhaps are all of ABC correct? Another question, and this is a special, as you know, an NRZL 0 question. Which of the following is true? ORS is appropriate even when a person with diarrhea is vomiting. Is this true or false? If IV therapy is not available, I cannot give ORS to my patient. Is this true or false? And C, oral solutions do not affect potassium levels. So 3 statements. Which of the following is true? Only one out of them is true. ORS is appropriate in vomiting. ORS cannot be given if IV therapy is not available. ORS does not affect the potassium levels. So with this discussion, let's move on to the questions for today. And we have lots and lots of questions and comments coming in. So from Dr. M.R. Chipa, can acarbose be used in malabsorption syndrome with hydrogen breath test positive and the higher side? You can use it, but it would not be a good idea, but it will actually worsen the symptoms. And as it is, there is malabsorption, so we are not going to gain much by reducing absorption further. In such a situation, the ideal course of treatment would be first to do a urine ketones, perhaps do a serum pH if that is available with you, and start the patient on insulin. In the meantime, you will be able to keep the patient safe and also find out why serum amylase is high. So insulin would be a drug of choice for this particular patient. Dr. Manju Vasudev queries, can we explain the rationale of giving OAD, oral hypoglycemic agent, before and after food? Yes, let me take this one by one. So now, some drugs are absorbed slowly and their effect is glucose independent. You want to reduce the insulin levels that are going up after a meal. Glipizide and glibenclamide. Please allow me to use the trade names, Glinase and Danil. These are to be given 30 minutes before a meal because it will take 30 minutes for these drugs to act. These drugs will be consumed. They will go to the beta cell. They will whip the beta cell to begin producing insulin. So it takes 30 minutes. If you give 30 minutes before a meal, the rise of glucose will be concordant with the rise of insulin coming from the beta cell, and overall postprandial hyperglycemia will come down. This was for glibenclamide and glipizide. For the newer sulfonylureas, the modern sulfonylureas like glimepiride and glyclazide MR, these are slow acting. They act through association and dissociation through the sulfonylurea receptors. If you give them even 5 minutes before a meal or with a meal, they will act very well. At the most, what is going to happen is that for the first 3 or 4 days, if you give the drug along with the meal, glucose control may not be optimal. But within 5 days, these drugs will reach steady state. They are long-acting drugs. They will reach steady state concentration, and then the control will be excellent. So the modern SUs are to be given with the meal or 5 minutes before the meal. Metformin, if it is sustained release, you can give anytime. If it is immediate release, we have metformin 500 and metformin 250 available in the country as immediate release. These should be given post-meal, after the meal, to prevent GI dysfunction. Pioglitazone can be given any time of the day. SGLT2 inhibitors should be given along with the first main meal. But it's not a very hard and fast rule. Even if the patient takes later on, there's no issue. Suppose your patient is a school teacher or a traffic policeman, then it would be a very bad idea to give this medicine at the beginning of the day while the patient is working. Patient will not be able to work properly. Patient might prefer that I'll go to work in the morning. When I come back at 3 o'clock, when I have a lunch, then I will take my SGLT2 inhibitor. So that is allowed. DPP4 inhibitors can be given with the meal. They are indirectly acting secretagogues. You can give immediately before or immediately after. It will not have an impact. For alpha glucosidase inhibitors, actually there is a difference. They should be taken with the first bite of the meal because they are going to prevent absorption. And some people actually say that you can take the tablet with water, or you can chew it also. You can chew acarbose. And some people say it has a better effect that way. So Dr. Kashinath Dixit from Bangalore has also pointed this out, that AGI should be taken with the first bite of meal. Thank you, Dr. Dixit, for pointing this out. The effect will be best, and the GI side effects will be minimum if it is taken this way. Acarbose you can chew also. You can tell your patient to do that. It is not bitter. There is no bitter aftertaste with acarbose. Dr. Jitendra Shah says, can AGIs be used in pregnancy and GDM? Theoretically, yes, they are category B drugs. So if, let us say, you have a patient with very mild GDM, patient is at 36, 37 weeks, just 1 or 2 weeks left for delivery, and there is no fetal distress, there is no maternal distress, you can try acarbose, though I have never used it in my practice. So if the patient has mild diabetes and you are anticipating treatment for just 1 or 2 weeks, there is no harm in trying. But on the ideally, it would be insulin. In the notes, you can mention that I discussed insulin with my patient. Patient was not willing. For most people with GDM, lifestyle modification, medical nutrition therapy, and insulin will work. But there will be 10% patients who do not respond to very high doses of insulin. Even after taking high doses of insulin, glucose levels are high. Postprandial glucose is high. PP excursion is very high. PP minus fasting, the gap is more than 74. In such cases, again, acarbose can be tried. So these were some questions. Dr. Hegde has a point. How do I treat fasting hyperglycemia with normal PP blood glucose? So the first thing is to tell your patient why this is occurring. How we speak with the patient is, fasting glucose is dependent upon overnight glucose release. Overnight glucose comes from the liver. It is a mechanism of the body to ensure safety even in times of prolonged fasting. It is not linked with lifestyle during the day. Only exception to this last sentence, that fasting hyperglycemia is not linked with lifestyle, the exceptions will be shift workers or people who drink heavily at night. On the other hand, daytime glucose is more linked with lifestyle. and with diet. So our first thing is tell the patient, thank you, madam. Thank you, sir, for taking care of yourself. Because you are following an active lifestyle, because you are managing stress very well, because you are following all the dietary modifications that we requested you to follow, you are doing a great job of controlling PP glucose. Thank you for that. Now, fasting glucose is a different ball game. This fasting glucose is coming from the liver. Your liver is trying to protect you, but it actually doesn't know that you are doing such a good job. So let us try to control this as well. We will use high dose of metformin at night. We can use basal insulin. If basal insulin is not working, we can use a better quality basal insulin like Degludec or Glargine U300. Degludec would be the drug of choice in this. If even these are not working, we can try a light anxiolytic dose, maybe half tablet of clonazepam 0.25 milligram or half tablet of Atrex 25 milligram at night. Tell the patient, I am not doing this to uh, give you an anti-sleep sleeping pill forever and ever. We are just trying to break the vicious cycle. Let us see what happens. Maybe you will sleep better and your fasting glucose will come out well. Usually these tricks work. Also, good idea to look at what the patient is taking at night. Now, normally we tell our patients you can drink as much milk as you want, but I assume that the patient is stopping at 250 ml or 500 ml. As much milk as you want, supposing patient reads this to mean 1 kg of milk at night. Obviously, high glucose levels will be high next day. So you look at what the patient is taking during dinner and after dinner. Maybe patient is drinking a lot of milk, maybe taking a mango at night, maybe taking a lot of alcohol. So just see what is going on and try to correct that as well. I hope, Dr. Ramesh, I've been able to answer the question and help your patients. Dr. Subhash says, up till what EGFR level can we use Voglibose? So up till mild, maybe we would like to stop at 45 to 30 ml per minute. Don't go below that. Dr. Gangadhar has a very important question. Can I combine DPP-4 inhibitor with sulfonylurea? The answer is yes. So both are secretagogues. Sulfonylurea is directly acting secretagogue. DPP-4 inhibitor is indirectly acting secretagogue. But DPP-4 inhibitors have other effects as well. Not only do they stimulate the beta cell to produce more insulin, they also sensitize the alpha cell. Sensitize means they make the alpha cell more responsive to ambient glucose. So when glucose levels are high, then the alpha cell will begin working. It will produce more. When glucose levels are low, then the alpha cell will begin working. It will produce more glucagon. But when glucose levels are high, there is no risk of hypoglycemia. The alpha cell will relax. It will relax. It will stop producing glucagon. This is what DPP-4 inhibitors and GLP-1 RA do. They are alpha cell sensitizers. When they become alpha cell sensitizers, when the alpha cell becomes sensitized, it produces less glucagon overall. Less glucagon means the beta cell also responds. It says, now there is no glucagon to fight with. Why should I work so hard? So it reduces the hyperinsulinemia. When that comes down, the alpha and beta cell begin working in tandem with each other. They begin reducing their secretions. They are able to de-stress, de-stress. We discussed this last week when we talked of incretin-based therapy. When they de-stress themselves, there is less need for sulfonylureas. So that is how sulfonylurea and DPP-4 inhibitor are able to help each other, help the patient control glucose. Question from Dr. Dinesh Trivedi. How do I choose between acarbose and Voglibose? So one would be personal preference. Acarbose is associated with more GI side effects. Voglibose has less GI side effects. Acarbose is said to be more effective in oryzovorous population. Oryzovorous means rice eating. So people who predominantly take rice will respond better to acarbose. People who predominantly take wheat will respond to both. So, but otherwise it will be personal preference for both of us. Dr. Rajeshwari shares an interesting case with us. So Dr. Rajeshwari shares a case of a 65-year-old obese male with type 2 diabetes on glimepiride, sitagliptin, metformin, and Voglibose. So this is 4 drug therapy with A1C more than 10. Now, since the patient is 65 years old, we assume that he has had diabetes for 10-50 years. I am just assuming. Chances of increasing the dose of glimepiride and getting good control will not be there. So finally, we will have to start insulin. We can stop glimepiride. and start premixed insulin. In patient with HbA1c more than 10, even basal insulin is not going to work. What the guidelines are telling you is basal insulin, but they have not imagined that person will be on 4 oral drug therapy and will have A1C of such high levels for such long period of time. So premixed insulin has to be given. We can stop glimepiride. We can give voglibose at lunchtime. So maybe premixed insulin breakfast and dinner, metformin, sitagliptin breakfast and dinner, and voglibose at lunch. Because the patient is obese, it will be very good idea, very good idea to add SGLT2 inhibitor. This will reduce the weight. It will improve glucose. It will reduce CV risk factors and improve CV outcomes. Before starting SGLT2 inhibitor, do check the serum creatinine and eGFR of your patient. If patient can afford, liraglutide would be a good drug in this patient. Suppose patient is very obese, patient says, I don't want to take insulin. Then you can offer another injection. Then you say, I'm giving you an injection. It is of the same family as sitagliptin. It will work much better than sitagliptin. So you continue everything else. Let us add an SGLT2 inhibitor in the morning and one injection of liraglutide, either in the morning or at night. This will reduce your appetite. Remember that sitagliptin and liraglutide cannot be given together. So these are multiple options. Let me rephrase. Try to add SGLT2 inhibitor. That would be for all. And then either we add premixed insulin and stop glimepiride, or we add liraglutide and stop sitagliptin. So these would be our options in this patient. If the patient is symptomatic because of diabetes, premixed insulin would be better. Insulin helps in improving symptoms. It is anabolic. If the patient is not symptomatic and atherosclerotic cardiovascular disease or its risk factors are weighing heavily on you or on the patient, there is a CV dysfunction or fear of poor CV outcomes, then liraglutide would be a better drug to begin with. You can also begin both. You can begin insulin and liraglutide, continue metformin in such cases. So we've had a lot of questions, and to everybody, I'd like to thank you all for being with me. It is a very good learning exercise for all of us, and I hope that we continue together on this journey towards learning and towards discovery. We want the best from our athletes, from all our representatives. I am a proud Indian, all of us are. We want our politicians to do the best for us. We want our athletes to win nothing less than gold. We have a right to expect this from them. But then we have a responsibility as well. And what our public, what our countrymen and women want from us is that we give the best possible medical care. That is what we are doing. Through Dr. K.K. Agarwal's Diabetes Essentials show, we are trying to empower ourselves, we are trying to equip ourselves, and we are trying to achieve excellence in our chosen field. And then we are trying to translate this excellence into good quality endocrine care and diabetes care. So with these final words, I'd like to thank you, and namaskar and Jai Hind.
Thank you, sir. And at the end of the session, I continue to request all our doctor viewers that the whole objective of having this session under Dr. Sanjay Kalra and in the memory of Dr. K.K. Agarwal is the motto which we have for the International Diabetic Federation 2021 is access to diabetes care. And as we all know that Dr. Sanjay Kalra is one of the finest endocrinologists we have in India. And today we have got around 15 to 16,000 general physicians and MD physicians are watching you. And that helps the achieving the objective of access to diabetes care in India, where we have got almost 10 crore pre-diabetic and diabetic populations are getting reported and getting treated by you who are watching us. Thank you very much, sir. And I request everyone to spread this as a word of mouth that every Sunday at 9 p.m. Dr. Sanjay Kalra will be here to take us on to 52 weeks Dr. K.K. Memorial's Diabetes Essential. Jai Hind.
Jai Hind.